And good afternoon, everyone. And thank you so much for joining us for the first session of the 2024 Older Adults and Opioids webinar series, hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor, the Western New York Rural Area Health Education Center, also a HRSA-funded education center. This is the 5th year we have been hosting these educational sessions, and thank you so much for tuning in and for your support on this topic. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center, and my co-host is Christine Chappell. She is the administrative coordinator at the Western New York Rural Area Health Education Center. We are so glad you can join us for our, again, 5th year of hosting this session. We do have a few housekeeping items before we get started. There are 2 very important buttons on your Zoom toolbar. Number 1, please use the chat button to type hello, introduce yourself with a name, job title, agency, location, whatever you'd like to share with us. We have people from 10 states and 2 countries who registered for today's session, which is super exciting. So welcome to everyone from all across New York State. We have Oklahoma, Tennessee, Michigan, Massachusetts, Illinois, Pennsylvania, Jersey, because I got to say Jersey, North Dakota, and Oregon, as well as registrants from Mexico and Australia for joining us here today. And if I missed your locations, please correct me in the chat. I am okay with that. Next, we have a Q&A button, and this will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question so that the question does not get lost in chat, and we will definitely leave time at the end of the session for questions today. So now I just want to go through the slides really quickly for you. Just introduce you to our session. We're having Dr. Chinazo Cunningham today talking about a public health approach to the overdose epidemic. And we are certified for CME, social work, physical therapy, occupational therapy, and mental health practitioner credits today. None of our speakers or planning committee have any conflicts of interest. We will email you instructions on how to claim your continuing education credits immediately following this session. We do ask that you allow up to 30 days to receive your credits. We don't email them out. You will have to log into the U of R portal for your CME and social work credits. And then Jason Fulkerson will be available to answer questions about the PT, OT, and mental health practitioner credits. And his email will be in the email that we send out at the end. No commercial funding was received to support this activity. And as a teaser for next month, just in case you haven't already registered, we do have Diana Padilla from the Opioid Response Network giving a session next month. So please use the QR code on your screen. And now I will stop sharing my slides and ask Dr. Cunningham to share her slides while I read her introduction. And Dr. Chinazo Cunningham is Commissioner for the New York State Office of Addiction Services and Supports, where she oversees one of the nation's largest systems of substance use and addiction services. She is a physician, trained in internal medicine and addiction medicine, and has spent over 25 years providing care, developing programs, and conducting research with people who use drugs. For decades, she has collaborated with community-based harm reduction organizations and led one of the first programs in the U.S. to integrate addiction treatment into primary care. Her work has focused on improving access to care, utilization of healthcare services, and health outcomes. Dr. Cunningham has authored over 150 peer-reviewed manuscripts and has been the principal investigator on numerous federally funded grants. In addition to serving on and chairing several national advisory committees and guideline committees, she has trained hundreds of physicians and has been recognized by local and national awards. We are so honored to have such a dedicated and knowledgeable practitioner with us today. So I will now turn the program over to Commissioner Cunningham.
Great. Thank you so much. And I'm very happy to be here today to talk about our public health approach to the overdose epidemic, and certainly going to focus on opioids and older adults as well. So just so that we're all on the same page, so I'm the Commissioner of the New York State Office of Addiction Services and Supports, also known as OASAS. And this is the mission statement for our agency. We really, our aim is to improve the lives of New Yorkers by leading a comprehensive system of addiction services for prevention, treatment, harm reduction, and recovery. So in our system, we oversee over 1,700 prevention, treatment, harm reduction, and recovery programs. And those programs serve over 680,000 individuals per year. And we operate, as the state, 12 addiction treatment centers. So this is an outline of what I'm going to be talking about over the next 53 minutes. Where we are in terms of state and national data on opioid use, overdose deaths, and the impact on older adults, our approach to older adults as we look forward, and then our guiding principles at OASAS that focus on using a data-driven, evidence-based approach, including harm reduction in our work and equity. So where are we now? So among Americans who are 65 years and older, 31% of them report opioid use. And it's a small percent, only 1.8% who report opioid misuse. Unfortunately, from our national data, from the National Survey on Drug Use and Health, we actually don't have estimates of the number of older adults who report opioid use disorder. And I think this is actually a problem. But if you take all substance use disorders, so any substance, 7% of older adults report having a substance use disorder. So again, not clear exactly how many are specific to opioid use. When you look at overdose deaths across the country, specifically focusing on older adults, this is a graph from 2000 to 2020. And you can see, first of all, that overdose deaths are increasing among older adults as they are among all Americans, and that the overdose death rate rose from 2.4 to 8.8 deaths per 100,000. So, more than the death rate, more than tripled over the last 20 years. We can also see from the graph that men in the darker green bar have a higher rate of overdose death than women who are in the lighter green bar. And this is true for older adults and really all Americans. And there are major disparities in who's dying. And so the majority of the highest overdose death rates are among Black men when compared to Hispanic individuals and white individuals. So now I'm going to take us to focus on New York and our data here. And so this is a graph showing overdose deaths in New York State by particular substance. And the first thing you can see, the black line is all overdose deaths. And this is from 2013 to 2022, with the 2022 data that are still provisional. And the bottom line, as you can see, that the number of overdose deaths continue to increase. When you look at what substances are really involved in that, the light blue line are opioids, and the red line is fentanyl and other synthetic opioids. So I think we all are, aware that really fentanyl is really driving so much of the overdose deaths here in New York and across the country. I think what's not getting enough attention is the role that stimulants is playing. And so the yellow line is cocaine and the purple line is methamphetamine. And what you can see here is that if you put those two together, all stimulants, it accounts for about half of overdose deaths. And so we tend to focus on opioids. And I know that this series of webinars is focused on opioids, but I want to make sure that we're also understanding the role that stimulants also has in overdose deaths. And so I think if sometimes when we focus too much on opioids, part of the downfall of that is that people who use stimulants may think that they are not at risk for overdose deaths when in fact they are. And most of that is because fentanyl is mixed into methamphetamines and cocaine. And so really with the drug supply right now, fentanyl's everywhere. So what does this mean? I mean, I told you numbers, but what does this actually look like across New York State? It means that a New Yorker is dying every 90 minutes. And so this is clearly the worst we've ever been in terms of this overdose epidemic. And this, these are people, right, with lives and families and communities that are really being destroyed. And so clearly we have a lot of urgency to think about how we can do things better and differently as the world has changed, the drug supply has changed, to make sure that we can actually prevent these overdose deaths because we know they're preventable. When we look across New York State, this is a map showing New York State on the left and then New York City counties on the right. And you can see here the crude rate of overdose deaths. The darker the color, the higher the overdose death rate. And so, while so many of the overdose deaths, of course, happen in the big cities in New York, what you can see here is that some of these counties, you may not be aware of how high the overdose death rates are, and particularly the southern tier, which is the area that's the southern part of New York, next to Pennsylvania. Definitely we see high rates there. And this is really important data for us at OASAS because we want to make sure that we are targeting our efforts and investments in areas that really have the highest risk. And then in New York, you can see that the Bronx is really highly affected. And this is, the Bronx, unfortunately, has had very high rates of overdose death for many, many years. And in fact, before I became commissioner, I worked in the Bronx for 22 years. And so I'm very familiar with the challenges there. So when you look at overdose deaths by age, this is a graph showing the different age groups in terms of overdose deaths. And so you can see here that most of the overdose deaths occur in those who are, 35 to sort of 64 years old, and then a small number of overdose deaths occur in older individuals. And then when you look at who's being admitted into our, treatment programs that are the OASAS certified treatment programs, it sort of follows a similar pattern, which is that most of the people in our treatment programs are, between the ages of 25 and 64. And then you can see that there's a small number of people who are admitted to our treatment programs that are older, 65 and older. So in terms of what kinds of programs people are enrolled in at OASAS, this is a bar showing, so we have a whole continuum of services, and these are the treatment services. So we talk about crisis services like opioid withdrawal management, and then we have inpatient services, outpatient services, the opioid treatment programs, which are really where methadone treatment occurs, and then residential services, which are sort of longer term. And so this graph is showing that the majority of people who are 65 or older are really getting services in either the opioid treatment programs, so methadone there, or in the outpatient services. And a really small number are getting services in these other areas. And so this graph is really about, on an average day, when we look at our system, who's in our system, these are the kind of services that they receive. And then when you look at who's in our system by substance, you can see here the light blue is heroin, the dark blue is other opioids. And so that accounts for the vast majority of people who are in our systems. But we can't forget about alcohol, and that's in the yellow. So again, I think we tend to focus on opioids, and certainly that's what's driving a lot of the overdoses, but we can't forget about alcohol, which is the most common substance used, right, because it's legal. And there's, a substantial number of people are receiving services because of alcohol use disorder. And then you can see there's really a smaller number of people who are getting services for other substances like cannabis and cocaine and others. So what are some of the key takeaways from the epidemiology here? So clearly the overdose epidemic, which is driven by fentanyl, continues to worsen and be a significant public health crisis in New York. And among those who are 65 and older and are using OASAS certified treatment programs, that those who are older represent a small proportion of people in our system. They also are most frequently using opioid treatment programs and outpatient programs, and the most common substance used is heroin, followed by alcohol. So, what's the path forward, given that this is the state of where we are right now? Well, I just want to make sure that we're all on the same page about opioid use disorder. It's a chronic medical condition. There is no cure. It requires lifelong management. We have very effective treatment. Treatment includes non-pharmacologic treatment, so like more behavioral treatment, like counseling, and then also pharmacologic treatment. There's only 3 medications that are FDA approved, including buprenorphine and methadone, the 2 opioid agonists, which have the strongest evidence, and then the opioid antagonist, naltrexone. So given kind of where we are and where the data really support the evidence, we know specifically that buprenorphine and methadone are highly effective treatments for opioid use disorder. They reduce the overdose death rate by 50%. That is much better than most other treatments in medicine in general. So when we think about cholesterol-lowering medications or blood pressure-lowering medications, they reduce death rate by 5%. So these medications reduce death by 50%. So much of our goal is to make sure that people have access to these life-saving treatments. So when we think about really treating older adults, we know that there are definitely unique challenges to being able to effectively treat older adults. We know that late onset substance use disorder, is certainly an entity that we can see in older adults, and sometimes that can be much more difficult to detect. Sometimes we know that signs of substance use disorder can also be taken as signs of aging. We know that there can be a reluctancy to enter treatment, and that treatment requires a targeted approach. So we certainly take these factors into consideration when thinking about how we can best treat older adults in New York. A lot of our work with older adults actually is around prevention. And so this is some of our prevention efforts for older adults that we're really excited about here. So we have a 9-county pilot project in which we're implementing prevention and wellness education for older adults. And this really combines 2 evidence-based interventions. So one is SBIRT, also it's called Screening, Brief Intervention, and Referral to Treatment. And then the other is called the WISE, which is a 6-session wellness initiative for senior education. And so we really combine these 2 to both sort of promote wellness, and prevention within that, but then also to detect use and early use so that we can do a brief intervention that can reduce the risk of going on and developing a substance use disorder. So in these initiatives, we partner with the New York State Office for the Aging and the New York State Department of Veterans Services. And we roll these initiatives out in really convenient settings. We want to make sure that we're reducing barriers to older individuals to get these services. And so we're doing this work in older adult housing, in churches, in community centers, and firehouses, et cetera, in these 9 counties. So we also know that it's really important. So those are sort of our prevention interventions to have, support and treatment for older adults who use opioids or who have opioid use disorder. And one example of our programs is a senior outpatient substance use disorder treatment program in Albany that focuses specifically on older adults who are 50 years of age or older. And so this is very person-centered and trauma-informed. And this is one example of the way in which we're really trying to target services and focusing on the specific needs of older adults. We're also working to try and reduce stigma and ageism towards substance use, and by doing that through some public campaigns, making sure that individuals have harm reduction, which I'm going to talk about in a little bit more detail in a couple of minutes. Building strong social networks. And so some of this is through our WISE program, which I just described before. And then also to make sure that we're identifying, coordinating, and treating co-occurring health needs. So, what we see too is that so many people are living longer, obviously, which is fantastic. And so when people, come in and are looking for services around a substance use disorder, so many more now have co-occurring, more complicated medical conditions. And so this is something that we're really working on, trying to be able to better address, because that was really not the case 10 or 20 years ago. And so we're seeing a lot more of the medical comorbidities, and we want to be able to obviously address both the addiction and the sort of more medical conditions. So I'm going to talk you through some of our guiding principles here. I've been the commissioner at OASAS for 2 years, and before becoming the commissioner, I had been working, on the ground, providing addiction services. And really what I learned is that we have to take a data-driven, evidence-based approach. We need to incorporate harm reduction, especially now, given that we're at the worst overdose epidemic ever on record, and given how deadly the drug supply is. And we also really need to focus on equity, given our history of racist drug policies. So in terms of data-driven approach, one of the goals that we have at OASAS is to make our data more meaningful. And so that means making better use of the data to guide our services, also making data more available and accessible to programs and to the public. And so we're doing this through some initiatives, including developing an addiction data bulletins. So we just released our first one, and we have a series of other ones which we plan to put out in this year. That are these bulletins that really describe specific aspects of our system or of what is happening across the state. So all of these are available. They're really meant for the general public to just get a better understanding of where we are. We also have a dashboard that I'm very excited about, a data dashboard, so that anybody can go onto the OASAS website and can see, who's in the treatment system, who's dying, what are the substances being used, in what region, and what age group, among, what gender. And so you can really, it's interactive, and so you can really use this information to understand what's happening in specific subgroups or specific regions of the state. I'm also very excited that we have very robust partnerships with academic institutions. We now have, I'm losing count, but I think 6 NIH-funded research projects where we're really taking a rigorous approach to evaluate some of our new initiatives. And I think this is so important because obviously, we want to make sure that the investments that we're making are really effective and are getting the kinds of results that we expect and that we want. And if they don't, then we should invest elsewhere. And so having rigorous, evaluation and research to guide those investments is critical. So just as an example of some of the work that we're doing in terms of data, this is a care continuum where we're looking across the state at New Yorkers who have Medicaid and new opioid use disorder. This is from 2015 to 2019. And when we look at the care continuum, we're really looking at who has an opioid use disorder diagnosis, who's engaged in care, who gets medication treatment initiated, and who's then retained on that medication. And you can see that there's a drop-off here at each step. You can also see for the medication, who's getting which medication. And so the majority of people, when they're initiating medication, are getting buprenorphine, that's the blue bar. And then the next greatest group is those who are getting methadone, the yellow bar. And you can see very few are getting naltrexone, which is the green bar. And then when you look at retention on medication, it's a little bit of a different story where many more people who are receiving methadone are retained in care than those who are receiving buprenorphine. So this is work that's really important for us because, we are doing specific initiatives that we hope are going to reduce the drop-off in this care continuum. So reaching people where they are so that we engage them in care and not waiting for them to come to us. So will we see less of a drop-off between diagnosis and engagement in care? Also working with our treatment providers to make sure they're expanding access to medication treatment. So will we see less of a drop-off between those who are engaged in care and those who initiate medication? So we are doing initiatives like that and using this framework of the care continuum to really evaluate at the population level what we're doing here at OASAS. Another example of our work is looking at overdose deaths after treatment is terminated. So this is an analysis that looks at people in New York City who had treatment terminated between 2016 and 2019. And that's over 51,000 individuals with treatment termination for any reason. And what we found was that there were 342 overdose deaths that occurred within 90 days of treatment termination. So that is equivalent to an overdose death rate of 6.6 per 1,000, which is extraordinarily high. Also a 7.3 drug overdose deaths per 100,000 person days. So this is extraordinarily high risk of overdose death following termination. And so this really, for us means that we need to understand who's the termination of treatment, why are people being terminated, and working with our programs to make sure that we are not discharging people inappropriately, making sure that we're using a harm reduction approach so that keeping people in care, even if they're not fully abstinent, still has a very protective effect. And then making sure that if people do leave treatment, that at least they leave with naloxone so that they can reduce an overdose if it were to happen. So certainly these data absolutely inform our work and guide our work with our programs. Also, in terms of data, we think it's so important to be transparent, right? And so this is, we have here our website for the opioid settlement funds. And so this is getting a lot of attention. In New York, in our fiscal year 23, we had $192 million from opioid settlement funds. So these were all the funds from litigation from pharmaceutical companies and distributing companies. And we have made all of the $192 million available. So this is for fiscal year 23. We are currently working on our fiscal year 24 dollars, which are a little bit over 200 million. And then we have for the opioid settlement funds, it moves forward for 18 years. We want to make sure that everybody can see exactly how these dollars were spent. And so we have a tracker on our website, and these dollars are really spent according to the recommendations made by the Opioid Settlement Fund Advisory Board. Their annual report, all of the meetings with the advisory board is on our website. And these are screenshots of what they recommended in terms of the priority areas. So you can see investments across the continuum. A lot of that is workforce. You can see harm reduction, recovery, housing, treatment, et cetera. And then you can also see that you can see by priority area how much money we spent, when the dollars went out the door. And then you can click on all of these and then actually see the programs that we funded. You can see how much money went to each county, what their proposed spending plan is. So there's a ton of information here. And again, our goal is to make these data available, make it transparent. It's not a secret. All the dollars are being spent to prevent and treat and address opioids and opioid use disorder. So definitely take a look. And again, OASAS, if you just Google OASAS and opioid settlements, you will get to this page. So moving on to harm reduction, just so we're all on the same page, harm reduction is a framework and a set of practical strategies that focus on reducing the harm associated with substance use. Some key principles include respecting the rights of people who use substances, because people will always use substances. That's what human beings do and have done for centuries. Acknowledge that there is a continuum of substance use. It includes abstinence all the way through risky use. And part of the goal is to get people to move to the healthier part of that continuum. It's to provide non-judgmental, low-threshold services, so really trying to reduce barriers for services, and then meeting people where they are. And that means meeting people where they are on the continuum of their substance use, but also literally meeting people where they are in their communities, in their homes, in the parks, in the homeless shelters, et cetera. And so we have many initiatives that we are doing that really embrace these principles. I hope you have all seen our public awareness campaign, really trying to get the word out about fentanyl, and making sure that people know that they could easily access harm reduction supplies, specifically naloxone and fentanyl test strips and xylazine test strips. So we were very pleased with our public awareness campaign. I'm going to show you some numbers afterwards in terms of the responses that we got, but it really focused on educating the public, providing easily accessible harm reduction resources. So we had QR codes on a lot of these that people could just scan and take them right to the webpage to order naloxone. We definitely reached a broad audience, and we were really focusing on communities that were really at highest risk for overdose death. So some of the ways that we are incorporating harm reduction across New York include, first, we established the Division of Harm Reduction at the Office of Addiction Services and Support. So very excited about that. It's been a year, and this division is the one that's overseeing all the harm reduction work. So a lot of it focuses on overdose prevention, so naloxone, fentanyl, and xylazine test strips. Also drug checking machines so that people can see what's in their substance. If they're going to use cocaine, is fentanyl in their cocaine, so they can then take, change their behaviors, either not use it or use a smaller amount or use it with naloxone nearby or some, ways to basically focus on keeping alive. And then also particularly for older adults, using expanding the use of drug deactivation bags. So this is the doTERRA bag here, and medication lock bags. So we know that older adults have a lot of pills, right, because of medical condition, and making sure that those pills don't get in the wrong hands. And so these are ways to safely destroy the medications and deactivate them. They're environmentally safe with the doTERRA bags, and they reduce the risk of people getting access to medications like opioids, and then also the lock bags, again, so that it reduces the risk of people getting access to medications that are not theirs. In addition, we also have outreach and engagement initiatives. And so this is part of that meeting people where they're at. So we do clinic level outreach and street level outreach. We fund these mobile units to go out and meet people in the communities, to meet those who are at highest risk. We have a homeless shelter initiative where we're providing services directly in the homeless shelter, again, not waiting for people to come to us. We're also providing care coordination and transportation because we know that people need this to be able to access services as well. So these are the kinds of harm reduction initiatives that we are supporting. So just to give you an idea of our successes here, for naloxone, which reverses opioid overdoses, we have distributed over 70,000 naloxone kits since having our public awareness campaign, and that's really been since August of 2022, so that's 6 months. And then our testing strips, which we have distributed over 4 million fentanyl test strips and over 3 million xylazine test strips. So clearly people are interested in this. There's a need for this. These are harm reduction supplies that can help save lives. And this is available on our website. You can see this screenshot here. And it takes 30 seconds, literally, putting in your name and address, and the supplies will be shipped out to you. So we ship them out to individuals who live in New York or any programs that are based in New York. So some examples of how we're expanding medication treatment. We know that there's regulatory changes since COVID, and there's also new funding like the opioid settlement funds. that really provide for new opportunities to expand treatment. So some of the ways that we're doing that I'm very excited about include mobile medication units. So we have 11 of these. So there are many parts of the state that don't have a brick and mortar opioid treatment program that provides methadone. And so these mobile units will go to parts of the state that don't have the brick and mortar programs and provide methadone treatment there. So we have funded 11. We've invested over $6 million. I think 3 are up and running now, with the other ones that are soon going to be up and running in the coming months. And we're partnering with jails, we're partnering with homeless shelters, we're going to parks, we're going to areas that we know there's a high concentration of substance use. And so this is really exciting for me. Again, going and meeting people where they're at, lowering barriers and delivering life-saving medication treatment, methadone. We're also working with programs to have more flexibility in their methadone dosing, because before COVID, many people were required to come in nearly daily to get their medication, and now that's changed. And so we're really trying to leverage these regulatory changes so that we can be more flexible with our dosing, again, increasing access and reducing barriers to care. We also have opioid treatment program satellites. So now, easier again to go to to have these satellite locations where there are no other brick and mortar opioid treatment programs to provide methadone. And then also integrating our outpatient programs with our opioid treatment programs, again, another way to expand access to methadone. So we're really trying to think about all the ways possible that we can expand access to methadone across the state. And I just have to say too, because fentanyl, when you think about the pharmacology of fentanyl, it's such a potent opioid. There's never been a time where actually methadone has been more important, because of the way the pharmacologic properties of methadone really match those of fentanyl much more than buprenorphine. And so given the drug supply, this is really, really important to be expanding methadone. We're also expanding treatment using telehealth. We have a low threshold buprenorphine program. And I'm really super proud of is that we now have mandated medication treatment in all 58 jails and 44 prisons in New York State. This has taken a tremendous amount of work, but we know that people who are involved in the criminal justice system are at extraordinarily high risk of overdose death. This will save lives. And so this has been really so important. And we are only the second state in the country that's doing this. The first state in the country is Rhode Island, and they have 1 jail and 1 prison. We have 58 jails and 44 prisons. So a little bit of a different scale here. Moving on to equity. So we know that we've had racist policies around drug use in this country. And we know that this has been shown in a lot of different ways. And this is one of the ways in which we see in the media. So different depictions of addiction by race and ethnicity. So, I worked in South Bronx for 22 years. Nearly every one of my patients is a person of color, and I have seen very directly how these policies have really destroyed communities. We had taken a criminal justice approach. We were incarcerating people because of their medical condition, addiction. We were blaming people, saying that it was their moral failing. And we really had a war on drugs, which was a war on Black and brown people. And, when there were changes in who was dying of opioid overdose deaths, more white communities, more affluent communities, there was really a change in the narrative. And so this change, really has led us to a public health approach, to more focusing on treatment than criminal justice, really focusing that this is a medical condition versus a moral failing. And overall, it's a gentler and a kinder approach. And that's all good, because this is a much more appropriate way to approach addiction and overdoses. It's just that it's a bit bittersweet in terms of the way that things happen and the reasons why. So when you look at who's dying of overdose death, I mentioned this briefly in the population that was 65 and older, but if you look at all of New Yorkers, you can see the black line that Black individuals are dying at the highest overdose death rate. Then the purple line are Alaskan Natives or American Indians, and then the gray line are Hispanic individuals. So the highest rates of overdose death in New York are really people of color. And these are data that we have to constantly be, following, because we need to make sure that we're investing in those individuals and subgroups that are at highest risk of overdosing. So part of what we've done at OASAS is to develop and establish our Office of Justice, Equity, Diversity, Inclusion. We call it our JEDI office. And this office leads all of our initiatives and really works across the whole system. So some of the activities that we've been doing is we have established a JEDI Advisory Council and internally. And so making sure that these principles and issues are addressed in prevention, treatment, recovery, harm reduction, in our regulations, and the way that we finance programs, really across the board. We're also doing our own sort of look inside in terms of our own organizational equity assessment. How are we doing? How do we need to change as an agency? We're looking at the language that we use to make sure that we're using appropriate language in all of our public-facing work. And then we've established a new way to think about procurement and have included questions for all of our programs about how they are incorporating equity into their programs and how does their leadership reflect who they serve. And the part of those questions are taken into account when we do the scoring in our procurement process. Some external activities, we're working across other state agencies to see how others, incorporate equity in their work so that we can learn from each other. We're developing trainings and tools and guidance for our providers so that, we can do some of that work up front to help them incorporate equity principles in their work. We're working to develop an Equity Leadership Institute so that we can make sure that people of color have the necessary support and skills to be able to take leadership positions in programs across the state, again, to reflect the populations that they serve. And then we're making sure that services are available in a variety of languages. We know there's so many languages that are, used across New York, and want to make sure that that our services are available for non-English speaking individuals. So, to summarize, we are experiencing the largest number of overdose deaths ever on record. And we know that although older adults are a small segment of overdose death populations, clearly this is an important population given their unique challenges. We know that opioid use disorder is a chronic disease with very effective treatment, and our goal is to make sure that that treatment is accessible to New Yorkers. We know that older adults have unique challenges and needs, and so we need to take that into account with programs that really focus on older adults. And we know that older adults make up a small proportion of those who are enrolled in the OASAS certified programs. And then finally, in terms of the guiding principles, it's really important for us at OASAS to make sure we're using a data-driven approach and using evidence-based strategies, that we're incorporating a harm reduction approach in our work, and that we're using an equity lens. So I am happy to take questions. I'm not totally sure how this is going to work.
Dr. Cunningham, thank you so much. That was such a wonderful and hopeful presentation that you just gave. We truly appreciate it. And we have a bunch of questions. I do invite participants now to please add your questions to the Q&A. We do have about 15 minutes, which will be amazing. I think we'll be able to get through them all. I am going to stop recording at this point in time, just because I think that will help folks feel a little bit less weird about adding questions. So I will stop recording.